Hello, everybody. My name's Iain Mallett. I'm the PPI manager for the NIHR Academy, and I'm here this afternoon with my colleague Alero Dabor, who is from the senior program manager for CCFs, the Central Commissioning Facility. And what we'll be doing today is a cut-down version of a workshop that was held at the Academy's conference last year. And what we'll be doing is including some thoughts and reflections of that session. So just a little bit about myself. You probably haven't encountered me, but I'm currently covering maternity cover at the Academy for PPI. But I come to you having worked in a number of organisations where I had responsibility for patient and public involvement and engagement, both at the public health in the UK Health Security Agency, and also I previously worked for the CRN doing patient and public involvement. And I've been doing it for, I would say, for a number of years, and variously, I've done public consultations. Most recently, I was part of a pre-design phase for a children's hospital in the east of England. So I have a variety of experience, but always very keen to learn new things. And my colleague Alero, I'm sure, has got a lot to share. She has a very unique position of being both a PPI professional, but also having been a public contributor herself. So hopefully, if she doesn't mind me saying it, she brings two sides of the coin in terms of being a PPI professional, but also having been a contributor herself. I don't know if you want to say hello, Alero.
Yeah, hello, good afternoon, everyone. And thank you very much, Iain, for the introduction.
Yes, so what we're going to be doing, if colleagues don't mind, this is going to be a fairly informal session. So Alero and I will be doing this a bit of a double act, but we do want to share with you very much what happened at the conference. And as the title of the session describes, thinking about embedding PPI in research, but with a particular focus on underserved communities and how you can integrate them into your research. Because of the number of people taking part, what we've decided, if it's okay, as was suggested in the first slide, if people have questions, could you put them in the Q&A tab? And if there are questions which seem similar to ones you would have asked, if you could vote for them, then we'll have a session at the end when we'll try and answer all your questions. If for some reason we can't, and there are a large number, what we'll do is we'll try and answer those in some of the feedback and the materials that you receive after the session. So you will get a copy of this presentation, so you don't need to scribble away. We will share it with you at the end, and I think we'll also be asking for a little bit of feedback as well, if that's okay, because I'm sure some of you are familiar with that there's quite a few series of these webinars, and we want to improve them, make them better, and do topics that would be relevant to yourselves. So please share your feedback. So what we're covering in this session is really to try and help you be better equipped to involve public and patients in your research. Some of the territory we might cover is familiar to you. I hope you bear with us. We have quite a wide-ranging audience today. Some of you I know are familiar with PPIE and have been doing it for a number of years as part of your research, but for some people, it's new territory, particularly early career researchers. So what we thought might be useful just to go over, what we mean by PPI briefly, talking a little bit about PPI and the research journey, but then getting on to the sort of the meat and bones, really, of how do you embed it in your research. I will be doing most of that session with, I'm sure, some contributions from Alero, but Alero will then sort of take more of a lead when we start talking about underserved communities, and they're working towards some useful hints and tips and suggestions for how you might embed PPI in your research, but also thinking about underserved communities. Unusual angle really here to show you a ship. What's a ship got to do with patient public involvement? But what I would say is, there's no great secret in patient and public involvement. Constantly ask yourself, could patients and public at any stage in your research make a contribution, and make it as seamless as possible rather than stop-start, but make it a sort of continuum of engagement. And what hopefully we can offer you is a few pointers today in terms of best practice, and share some of our experiences. And I know Alero likes stories, and this is an interesting story in relation to, you may remember a few years ago, the UK polar research vessel, there was a competition to rename it. And it was a little bit of a, I suppose it's light-hearted really, but a reflection on the fact of being clear about what you're asking people to contribute to. And so rather than give some what might seem some sensible parameters, what happened was they were asked to think of a name, and the name they came up was Boaty McBoatface, which in reality was probably not particularly practical for a large vessel like that. So they ended up calling their autonomous sub Boaty McBoatface, and the main ships the Attenborough. But joking aside, I think what it just shows is just be very clear about what you're asking, and when you're involving people, and make it clear, set the parameters, because then that saves confusion in the long run. So let's say a light-hearted example really, but thinking about, you know, what is involvement and what do we mean by involvement, engagement and participation. And I think these words are often used interchangeably, and that actually for the NIHR, we particularly ascribe meanings to these words. And I think it's quite important to be clear the difference that we make in terms of, you know, the pyramid. Some people call it a pyramid, some people call it continuum. And I think for the NIHR, really for us, it's about the difference between involvement is the sort of should be with and by members of the public as participants, rather than to, about, or for. So it's that active partnership, and making sure that, you know, public can influence and shape research. But also the word public is a word that is used a lot, and, you know, that should be everybody, but we need to think about how we divide that up between patients, carers, people who use health services, and thinking also about the power of lived experience. And that is really important in terms of shaping research. I don't know if you want to say anything about that, Alero, putting you on the spot, but, you know, from your experience, the power of lived experience is very important, isn't it, in terms of involvement?
Yeah, in terms of involvement, the power of the lived experience is, yeah, it's extremely important. And that's because, as Iain has alluded to, I like stories. It's because from your lived experience, you can tell a story. And by telling your story, a researcher can actually untangle what you're trying to say. But it's only the person who has that experience that can speak to the experience. And I think that's why it's quite important. And I'll give an example, and I'll give myself as a personal example in terms of lived experience. When I was diagnosed with cancer and I lost my hair, and I was sent somewhere to get a wig, I was given a Caucasian wig. Prior to that time, I had not even, I think I was in denial in terms of the cancer. But the minute I was given a blonde wig, I burst into tears. And I think that lived experience, it would live with me for a very long time, because one, I don't know how they would have got to that position. And then two, how did you get to that stage if you didn't involve people and have representation? So I think the lived experience is important, because if they had asked me, the chances of me asking for a blonde or a brunette wig might have been very slim. So, and it's in getting people involved right from the outset, and that would have influenced the choices that we would have been able to make.
Yeah.
Iain?
Thank you, Larry. No, that's very helpful. And you know, there are so many points at which there are opportunities for involvement, as I'm sure you're aware. whether it's supporting as co-applicants, as part of research, helping to set priorities, being a member of an advisory group, developing patient information, undertaking some of the research for you as well. But really, for us, that's quite clearly what involvement is, compared to, say, what engagement might be, which is very much the information and knowledge sharing. So typically we're thinking about science festivals, open days, working with the media, generally to raise awareness. While participation is taking part in the research itself and maybe part of recruitment as well. So, not to labour the point, but, they are three very distinct activities, but, they are linked, and quite useful to remember those differences. So why do we involve patients in the public in research? Obviously it's a good thing. It's increasingly becoming an expectation. And quite clearly, as researchers, you're expected to provide rationales for the way that you do it, to articulate how you might do that involvement. But there are some other drivers as well, which here we're talking about, democracy, democratic rights, the individual's right to have a say in their treatment, but also it empowers people and gives them the opportunity to influence and shape research. But also it provides perspective, as I think Alero has alluded to. There are many different views, and if you don't get the different perspectives of the people taking part in research, there's a loss there. And community experience for many people is what's missing. So that opportunity to hear perspectives, it improves the quality of the research, tailoring your research to the needs of those communities. Hopefully it means you can improve the recruitment and retention. We hear about people who take part in research but decide that it's not for them for a variety of reasons. Sometimes about the quality of the communications they see, or sensitivity to their needs, as Alero has alluded to. And also it makes it relevant, prioritising, understanding what the priorities are of the participants. And sometimes it may not be something that initially occurs to you, or, for example, an emphasis on prioritising symptoms and treatment of symptoms, rather than perhaps clinical outcomes in their purest forms. And not least that, it is increasingly becoming a requirement. Funding bodies expect it. It's often part of the application process. I'm sure you're well aware that the NIHR has a standard application form, and within it there is a requirement to describe how you're going to involve the public in the designing and planning of your study, right down to budgetary requirements. And you may even find that the public and patients are part of the selection panels themselves. So I'm sure you're aware at the Academy, our selection panels for our fellowships include patient and public representatives who evaluate the patient and public involvement element of the application. And to a lesser extent, it is sometimes an ethical requirement. I know it's not in every single case, but increasingly, as part of ethical approval, there is a requirement to show patient and public involvement. And again, within those panels, you'll find that there are members of the public who are scrutinising what you do. So just trying to think about the journey. What we've got here is
Iain,
sorry,
if I may, the previous slide.
Yes.
There's something that you mentioned in terms of retention.
Yes.
I'd like to say that if people are providing a different perspective, and if patients and the public are improving the quality of research, and if researchers make the research relevant, the chances are that you will be able to retain patients and the public, because more often than not, people with lived experience, or the carers, or the people who take part in this research are quite passionate about what they're doing. And if you're able to follow the right pathway, you're able to keep them and retain them. Because one of the things that I have observed or that has come to my attention is if it's done haphazardly or not wholeheartedly, people will drop out, and they find it very difficult to understand why people do not stay. And it's for these reasons that you have pointed out, Iain, that people do not stay with researchers, because they feel either A, their voices are not heard, or it's not relevant. They haven't got them on board right from the outset. They've not discussed the topics with them. They've not identified, find out really what is it that you want, not removing from the researcher the actual piece of research that needs to be done. And if they're able to identify and prioritize the piece of research from the outset with the public and patients, then that should never happen, because they would have helped to shape it. And if you're a part of something, the chances of you leaving is very slim. If you feel you belong to something, you want to continue. Thank you, Iain.
Yeah, no, that's a very valid point. Thank you for pointing that out. What we've got here, I'm not going to labour this too much, but shows quite a high level of strategic opportunity to involve stakeholders in general, but there's some important points here in terms of thinking about when you can involve patients and the public. So in those early stages of priority setting, at the design stage, delivery, your reporting stage, impact and dissemination. So there are sort of staging points along the way at which you could do involvement. But what I would suggest and hope that looking more in terms of that continuum and timeline, that rather than stop-start, that you do it throughout. And while the next slide looks like a great big long list, which it is, I'm not going to go through every single point, but this is starting to reflect some of the discussions that were had at the workshop, and the opportunities for which the sort of patients and public thought that they could become involved. And clearly there are a large number there. And I think particularly there's sort of where I think sometimes we get a bit of negative feedback from the public and patients and contributors, is that they're not involved in that what might be called the sort of discovery phase, the very beginning, when colleagues are formulating their ideas, thinking about questions, feel that perhaps they need to be clearer in their thinking and therefore be able to present to participants specific sets of questions and ideas. But increasingly what we get the message is that they would like to be involved in a really early stage and not to be frightened of that. And Alero, I hope you'd agree with that based on your experience, which is the stage at which colleagues become, contributors become involved, and that they feel that the design has already been set. I would hope you'd agree with that. I don't know
yes, I definitely agree with that.
I agree.
I agree with you.
Yes. So yes, it's often at the point at which the writing of applications take place, which I'm sure you're familiar with, and that contributors say, they're happy to write the lay summaries and provide suggestions, but would have probably appreciated an earlier opportunity to get involved. And then I think the area that often causes an issue is around recruitment. How do you get the people involved? Who are they? Where are they? And I suppose the important learning is that you're rarely starting from scratch. Whether it's a particular topic you're looking at or a community, there's some really good networks out there. I know that the local clinical networks have their networks as well, but also working with sort of charitable and voluntary sector, in my experience, have been really helpful. I had to do a piece of research looking at some long-term conditions, working with rough sleepers, and actually for me the best way of doing that was working through the homeless charity St Mungo's. They were able to do the outreach work. They had the trust of the rough sleepers, homeless people, and the charity was very keen to do that engagement. So there are existing networks that can help with recruitment, and very often you find people have taken part in research before and maybe they haven't had a great experience, so they look to trusted people, so certainly worth exploring. And also the sort of then there's often a gap, and but contributors can help in that monitoring phase, helping you to reach out, helping you to collect data potentially. They're often very keen to do that. It does mean that sometimes you have to factor in a bit of training to help them collect data for you. But there is real value in teaching them. I think there's a tendency to think that participants really can only help with qualitative data. But actually some of them have some experience around quantitative data analysis, so they can go beyond the sort of helping you to, while it's useful, delve into some of the themes that maybe your research is producing through qualitative research. But in terms of quantitative as well, there's good evidence that they can do that. And we certainly had some people at the conference who said that they would welcome that opportunity to be given that training. And then there's the sort of the final phase, which is, the dissemination, helping to identify channels that, through their community groups, through their networks. Very often the feedback is that they didn't know what became of the research, what was the outcome, that makes them want to take part in more research, but also to share it with communities, share it with clinicians, people they have contact with as well. So that was some of the initial thoughts, but they also came up with a different way of looking at things, about integrating PPI into research. So this is sort of the language that the public participants used. So they talked about the Eureka moments, those moments when the funding calls come in, you sit down and you start thinking of that brainstorming phase, and that they would welcome that opportunity as well. And it constantly goes back to this, involve them as early as possible. Again, Alero, sorry, I keep putting you on the spot, but I mean, you were there in terms of the sort of the Eureka moments. Did they talk about that as well? Did they say, was there any takeaways for you from listening to what the participants said about being involved early?
I think that it was a Eureka moment in the sense that some of the researchers, I think, began to embrace or understand why the public and patients should be involved from the identifying and prioritizing of the research topic. So that was a Eureka moment. And I think another Eureka moment for me, what I would say in terms of people with lived experience, is one thing I think, based on my experience and in the workplace, is that we had lives before we had an illness. And I think that is something that researchers tend to overlook. And this is where the data analysis and all these other things come into play. Is that if you understand the people you're working with, you will understand that they had a life before that. Some of the contributors that I've sat alongside are medical journalists, they're statisticians, they're mathematicians. It's something that's been taken away from them, and being given the opportunity to participate now in this piece of research is one of the best things that they would like to do, because all of a sudden they become human again. And I think it's actually understanding where and what. And for researchers, I think what I would ask them to take away is ask the question. Ask the question, would you be interested in the data analysis? Would you be interested in the qualitative? Would you be interested in the quantitative? It's little things like that that go amiss. And this is one of the best ways you can integrate people into your research, irrespective, and not just always think it's about the plain summary or the plain English summary, or it's just not about reading the application. It's also trying to empower and embed another person in your piece of research, which I know it could be very difficult because it's your baby. But I still feel that even though it's your baby, people can help you massage that baby into something great. So that for me is like one of the Eureka moments that hasn't really been grasped.
Yeah. Thank you. And yes, I mean, I think that's also some of the feedback that I got, that there's sometimes a bit of, in terms of choosing the right questions to ask as part of the research, you know, a mistaken belief that public contributors wouldn't know how to contribute to that question, and using their lived experience can help shape the question. And I think also what happens is, and you know, I think we're all conscious of the process of which you have to go through the various planning stages and applications, that to involve the contributors in essentially when you've got to that second stage and you're making the pitch, that there's only a certain number of people sometimes who are allowed to participate in that second stage panel, and that while the technical side is really important, obviously, in terms of your research, there's only often space for 2 or 3 people, and that rather than bringing a public contributor along as part of that panel, people might think, well, you know, we need the technical experts there, but it can actually be quite powerful to have a public contributor there. So I would say, you know, think about their voice and the power of making it a meaningful piece of research. And as you say, Alero, the tendency is to get them involved in the plain language summaries and, you know, as you get towards the end of the research. But increasingly, we're finding that public contributors are often co-authors of academic papers. They're starting to understand the process much more, and therefore consider them, take them with you. I think it impresses the panels when you're making those applications. I'm conscious that I'm sort of I've talked quite a lot and taken up a fair bit of the time, and we're sort of roughly halfway through, I think. So what I was going to do now was turn a bit more to you, Alero, to talk about, well, you know, I've sort of set the scene, you know, why do we do public involvement? How do we start thinking about integrating it, some of the questions. But the area people are increasingly interested is thinking about underserved communities. And I know it's not an easy subject because, you know, we talk about, you know, what do we mean by underserved communities? And I think it's quite complex and quite intersectional. Nobody actually fits into a neat box. We're all different kinds of people with different health conditions, lived experience. So I think that graphic quite helpfully shows the sort of the nature of the sort of crossover that we experience with trying to put people into categories, but it's important to think about it. So Larry, are you okay to start talking? Sorry, now shut up.
Yeah, I think this slide says it all, because here we have the ability, gender expression, language, political affiliation, sexual orientation, occupation. We have to bear in mind at some point we may all be termed underserved. It really depends on where you are in life and what really happens. So the key idea here is that the definition of underserved is highly context specific. It will depend on the population, the condition under study, the question being asked by research teams, and the intervention being tested. No single simple definition can encompass all underserved groups. So I would like to say, so what do we mean? If I may have the next slide, please. What do we mean by underserved communities? Underserved communities are people facing intentional and unintentional barriers to social, economic, and health participation due to protected characteristics, service provider biases, lack of awareness and assumptions about service users, patients, and clients, structural arrangements and design. Most underserved community characteristics are protected under the Equality Act, but not all, for example, carers and the socially excluded. I think it would be important for me to say that the NIHR defines underserved as follows. The NIHR Include project identified the term underserved by diverse stakeholders, including patients and the public, as the most appropriate term through a consensus workshop. The term has subsequently been adopted by the NIHR and more widely. The term reflects the perspective of research community needs to provide a better service for people in these groups. The lack of inclusion is not due to any fault of members of these groups. The term underserved reminds us of this perspective in a way that alternative terms such as underrepresented do not. So the work of the NIHR project shows that no single definition for an underserved group. Some key characteristics are common to several underserved groups, and they are lower inclusion in research than one would expect from population estimates, high healthcare burden that is not matched by the volume of research designed by the group, important differences in how a group responds to or engages with healthcare interventions compared to other groups, with research neglecting to address these factors. So I think this really covers what we mean by an underserved community. So Iain, if you wish to add to that, that would be great.
Yeah, I mean, I think from sort of my perspective, having worked in public health and through the pandemic, what it reiterated is that, you know, the using that term underserved, that those communities carry the greatest burden, you know, in terms of health inequalities, that they suffered most during the pandemic, and that, you know, the importance of focusing research on those communities, you know, can't be undervalued. And I know many of us that we understand that. I suppose what I would say is that, you know, this slide talks about the sort of what legislation says and what we're used to talking about, but we need to go beyond that, and hence the term underserved, that it's contextual and that we change from time to time. It's like, you know, at various points, I mean, we're all patients, but there may be times when our need is greater in terms of a patient, and therefore not to be too, forgive my language, hung up by using the sort of what the Equality Act says. Very importantly, yes, the characteristics, but we need to think more broadly than that. And, you know, as it says, you know, carers aren't included under the Equality Act, but we know they're a really important source of information, lived experience, knowledge, but also their health is often not as good due to their sort of caring commitment. So I think it's a sort of, as you alluded to, Larry, it's a perspective, it's a state of mind, and that, you know, we can't just put people into simple boxes and say that that's an underserved community, because any of us at any one time could be underserved based on our experience. So yeah. I think that's a really important point.
Yeah, thank you, Iain. I just want everybody to know that we are seeing some of the questions, and I know some interesting questions have been raised. So hopefully we'll get through this and be able to answer your questions. Thank you. So why is it important to include underserved groups and communities in research? And the reason is because if we don't, we'll fail to reflect the population. We'll fail to balance the risk and benefit for target groups. We'll have lack of evidence for all groups. And research needs to collect evidence from a wide range of groups. As they say, no decision about me without me. I think that really is what it is. So
you want the next one? Oh, sorry, going the wrong way. Yeah. You may have this is my first webinar. I shouldn't admit to that, should I?
So the barriers to inclusion of underserved groups, and this is something that we need to think about. The type of barriers we think about: accessibility, for example, physical, educational location, lack of motivation due to low expectations, cultural fear of clinical trials or need for community consent, lack of trust in authority, poor understanding of risk and benefit, no perceived incentives, lack of time and regular hours. When we look at these barriers as a researcher, these are the things that you should consider, like the lack of time and regular hours. Once upon a time, I understood that a clinical trial did not take place because they asked the senior citizens to come in at 8 o'clock or 8:30. And nobody asked them. So I think somebody did ask, so why? They said because their freedom passes or, you know, their oysters start at 9:30 and not before. That didn't click. It was just such a simple barrier that you would have not served those people and they would not have taken part in the clinical trial. And as a result, it wouldn't have worked. But just changing that slight thing, but nobody thought about it apart from the people who were actually experiencing it. And again, the lack of trust in authority. I think we hear that time and time again. And if you want to serve a group of people, especially in a community, one of the things that I would recommend is you become a part of that community. You become a part of that community, embed yourself in that community. I think, being on the research side of things, I think with all due respect, research is not a sprint, it's a marathon. PPIE and looking at all the things that we have to look at with the inclusion of the underserved is not a sprint, it's a marathon. So you should take your time to go through these things, to dot your I's, cross your T's, talk to the right people. And when I say talk to the right people, I can say, for example, is that in some communities you have what we call the gatekeepers. But we know you don't want to speak to the gatekeeper. You want the gatekeeper to open the door so that you can speak to the people inside. But you have to liaise first with the gatekeeper of that community, any community, to understand what is needed, and they will be able to direct you. In terms of the lack of motivation due to expectations, there's so many communities, there's so many underserved people. It doesn't matter what color, race, religion, or creed you are, but some people are underserved. I mean, the average age in the UK for reading or studying reading age is 8 or 9. So you can imagine going somewhere, trying to do your presentation or your research, and you don't understand that some people already have the barrier because, one, their reading age is so limited, but they're not going to tell you that. It would be for you to kind of tease it out. So those are kind of things that I taught, for me, it's very particular how you try to assess and address and try to understand the barriers.
Yeah, and I would agree with that, Alero. Certainly on the educational side, I think there's often a perception that, if English isn't your first language, or you've had a little amount of attainment educationally, that you're not qualified enough to take part in research. And as you said, it's about traveling to places and at times of day, and that people often from disadvantaged communities don't have the flexibility to come to things 9 to 5, that running events in the evening or on weekends. Certainly I've done that over the years, and I think that's made a difference in terms of being able to participate. And also the incentives, that it's not just about the recognition payments that you should receive as someone taking part in research, but what is the benefit to you when you're not used to receiving any benefit from society? The motivation to participate is very low. When you're at the end of the queue all the time, will you get any of the benefits? So there's some important questions there. Yeah, I agree.
Thank you, Iain. The next slide is yours, Iain.
Okay. Oh, right. Okay. So it was just coming back to me really to try and think, well, constructively, how can we think about inclusion? I mean, I think we've sort of touched on these already, but just remembering what the demographics are of the population you're going to be working with, what criteria do you use? If you're going to exclude anybody, why is that? Is that because of resource and time, or are you going to prioritize some people over others? Thinking about recruitment, as Alero said, it's about going to the community, engaging with them, finding out who is going to help you recruit. Certainly from my experience of working in public health, faith leaders play a really important role in some communities. It is worth investing the time engaging with them. Some of my colleagues have taken part in some podcasts with faith leaders, made a real difference during the pandemic, as encouraging members of their community to take part. Ultimately, the evidence that you accumulate, will it reach as broad a range of society, or you're going to be missing people out? And the outcomes, are those outcomes specific to everybody? Can everybody benefit from them? So they're just some of the questions I think we should be asking ourselves. So here is, I'm sure we could talk for a very long time about, how to do it, but these are some of the thoughts and reflections that Alero and I had about involving underserved communities. So, being aware of the barriers, that, we've got competition there. There are other people out there who may be doing similar parts of research. And if your pool is relatively small, what's the incentive to take part in your research over others?
Iain,
Sorry,
Iain,
Larry, sorry.
Sorry, everybody. I'm conscious that the
No,
time is almost up,
sorry,
and we
sorry.
will be giving you the slides. So, Iain, if you don't mind,
stop talking to them. Yeah, no, that's okay.
No, if you don't mind, can we answer some of the questions?
Yeah, sure. No, I think we've covered this now.
We've covered most of it.
So yeah, happy to go forward. So again, this is just a graphic, another way of representing, thinking about involving patients, public in your research. As Lara says, it will be part of the takeaways for you, so you can use them. I just finishing for the questions. Really, it's just some takeaways, thinking about primary things about remembering to get feedback from your participants, listen to them, tell them how they've made an impact so they stay on board, say thank you. It's a surprising number of times that we forget to thank people taking part in research. Look at your diversity, and also be just that hot off the press, which is there's always a lot of guidance. We can share our guidance, but literally in the last day or two, NHS England's produced a set of guidance on diversity inclusion in research. There's the link there. Please go and take a look at it. Thank you. So yes, over to questions. I think we've got quite a few.
We've got quite a few.
Yes. So okay. I think what I'm looking at my colleague here who's a bit more experienced. So I think I've gone to the one that's had the most votes, which is, what is your recommendation for trying to recruit participants for PPI? Social media is one avenue, but obviously this has some bias in terms of those who may engage. What do you think, Alero? You answer it, or you do it together?
When you say, this is when we say participants, again, this is one of the reasons why we try to distinguish. When you say participants, are we talking about participants in a clinical trial or participants in PPIE, public and patient involvement? So I would really need to clarification on that.
Right. Okay. I mean, I think generally, I think there is a point around the power of social media. Obviously, there's very active communities, and it can be useful. I think the difficulty is what's being alluded to here is, that the social exclusion element, which not everybody accesses social media. And recently, I did some work with young people, and you kind of assume that all young people are active on social media, but if they've been the victim of bullying or harassment, some don't use it. And I think it's the golden rule of all communications and engagement, which is one size doesn't fit all. Social media can be useful, but I think working through others is always very powerful. So, what I did was, in order to get, young people from as across the range as I could, I contacted some voluntary organisations and some youth councils, and they were very helpful in providing people who maybe were perhaps not in full-time education or the usual routes. And I think you do need to do a little bit of lateral thinking. So I think social media has its place, but I would suggest that it's worth exploring other avenues as well. So looking at voluntary organisation, third sector, those sorts of places certainly been very useful for me in the past.
And outreach.
Yeah,
I think outreach is so important. If you know what your community or the people you want to engage in, think of where they huddle up together and physically go there. Outreach is so, since COVID, outreach is so important, because now you have the food banks, to get people in food banks, you have so many different things coming up because of the cost of living. So you really have to be creative and think outside the box, as long as you identify your group or the target audience, the people you want to get involved in your piece of research.
yes, it's those touch points, isn't it? I know colleagues in local authority are making every contact count, as they call it. Next question, I think it's more aimed at you, Alero, and I think what it's trying to do is saying, have you been involved in co-production of research? And if so, do you have any thoughts on how this may differ from PPI, or any thoughts about how we can ensure researchers can include underserved communities within this? So I think it's the difference between co-production and patient and public involvement, and how have you been involved in co-production?
It's quite a long question in terms of
it is, yes.
it's quite a long question. I don't think you can separate co-production from public and patient involvement, because if you're going to be co-product, you would have already been somebody who was already involved, and the chances are that the researcher would have asked you if you're going to co-produce in this. So yes, I have co-produced. So what is the other part of the question? And that is because I was interested in the piece of research. I was interested in the researcher because the researcher was interested in me. So there was a lot of interest going on here, because again, it's going with the journey. And I think I spent 4 years with that researcher co-producing the work that we needed to produce. So it's a case of interest. And then yes, as a public contributor, I would become a co-producer. So they're not separate.
No, part of a continuum, I suppose.
Yes, it's part of a continuum, and it's identifying that I had the skills and the ability to be able to do it. So again, identification is important, because I had a life before I was ill. I had a life and I had skills that I could bring to the table, and then I could also upskill with what the researcher. So it was a win-win situation. So co-production is very, very useful and helpful. Any other part of the question?
Well, I think it was really just sort of saying that, asking if you've been involved in co-production, but I suppose it's that sort of when the difference between co-production and PPI.
It's the next level, isn't it? Co-production is just going another level, and it's a more one-to-one with the researcher.
Yeah, more of a partnership.
Yeah.
Okay. Right. Okay. Ooh, sorry, it's moving very quick. I've got one here about language. Plain English is very important to use. Several terms have been used in this webinar: intersectionality, characteristics. I don't know what they mean, and they could be open to misinterpretation. That's a good point, actually. We did slip those in. Do you want to, which one of us wants to explain intersectionality?
That's you, Iain.
Okay. I think that was really our Venn diagrams, really. When people talk about intersectionality, people rarely fit into one box or another. So someone might have a disability, but they may also be LGBT, for example, and therefore needing to think about their needs that, you know, might be different, similar to others, and not assuming that just because their disability or their issues related to disability, and likewise if they're LGBT. That's the language. Apologies, I think it's one sociologists tend to use. In terms of protected characteristics, that's the language described in the Equality Act. Again, not particularly helpful and not particularly humanizing, but the protected characteristics being, I think there are, now this is a test for me, I think there's 9, got that wrong, yes, so you're quite right. We need to be careful, and if we confuse each other by using language that is not clear, then how are we going to be able to engage with other groups and public as well? So you're quite right. Well reminded, I guess. Okay, I'm just looking at the next. How are we doing for time?
For time, we've run over time.
Over time. Oh dear, I'm so sorry.
I think we may have to answer the questions and thank you and send it on.
Yes, I can see there's quite a few questions.
There are quite a few questions. And very interesting questions for that matter. So it's a shame we don't have the time to.
Yes. I mean, this is just the tip of the iceberg. And I would say that, you know, certainly in your feedback, if there's certain areas that you would like us to explore, I mean, already I can see that there's some questions around, again, that continuum of involvement, engagement and participation. And clearly, yes, there's often a bit of debate around engagement and communications. And I know it's split in different ways as well. So I think it's an important discussion to have. And certainly we might even want to bring in a future one, some of our communications colleagues to talk about how they address some of the issues about targeting their communications, because it was all very well for me to say there are different communities, different communications channels, one size doesn't fit all, but how do they accommodate that as all? And there was an important question about budgets as well, which we might be able to provide a bit of information on as well. So we could answer all those questions. So I suppose now we've run out of time, so apologies, but thank you very much. There is more, I'm going the wrong way here on our final slide. So we will, this webinar will be available shortly. And if you email us, we can provide you with copies of slides, and also be really interested to hear your feedback if you could share it with us. So thank you very much. And I'd just like to say thank you to my colleague Vicky, because she sort of stepped into the breach to help me. As I say, I've not done a webinar before, so thank you very much, and thank you for listening, and thank you to Alero as well.
And thank you. Yeah, one of the questions that we will be able to circulate the answers to the questions not answered, and we'll send that with the slides. So yeah. Thank you for bringing that to our attention as well. So we'll try our best possible to answer everybody's question.
Yes, so thank you very much, everyone.
Thank you. Okay.